Hi, everyone. Thank you so much for joining us for the last session of the virtual SIR 2020. It's my pleasure to be co-hosting this session with one of my dear friends, Dr. Divya Sridhar. And what we're going to do today is go through some topics, very important topics with respect to women's health. And we have an excellent panel of thought leaders who all happen to be women in the field of interventional radiology. It is my great pleasure to introduce Dr. Divya Sridhar from Harlem Hospital, who's going to talk about women in IR and the COVID-19 pandemic.
Thank you so much, Maureen. Let me just share my screen. All right, so thank you everyone for joining us, and hello from New York. In putting together this session for the inaugural, hopefully last virtual SIR meeting, we realized that any discussion of women's health from the IR perspective at this time would be incomplete without a discussion of the health of the women practicing IR. And in particular, the impact of the COVID-19 pandemic on the health of those women. No disclosures. So when we look at health, I think about a few different perspectives on health. One is the overall health of the initiative of bringing more women into IR with the goal of achieving gender parity. And we'll look at some of the growth in numbers and really some of the strides that SIR has taken to improve the overall health of the Women in IR initiative, and then move on to a more focused discussion of the impact of the COVID-19 pandemic on the health of women in IR. And I think the most obvious, or the first consideration a lot of us would have, is the consideration of physical health, and particularly the special considerations and risks of pregnancy. But there are also other health parameters that are impacted by this pandemic, and notably psychosocial health with regard to work-life balance and burnout, and finally professional health and advancement. And I know that Maureen agrees with me in this regard, but in describing challenges, we find it really important to immediately also discuss solutions and to look at identification of challenges as an opportunity. So looking at the health of women in IR as an initiative and as a goal of achieving gender parity, we have been achieving some success. There is certainly a growing number of women in IR. We also have a long way to go. According to the most recent AAMC data, which admittedly is a couple of years old, from 2017, about 9.2% of active IRs were women at that time. And that number is higher than previous headcounts, but still we have a ways to go. SIR has really taken an active and robust role in trying to increase the presence and number of women in IR. And that has been achieved really across various different levels, which I think is important to note, that the overall increase in SIR membership among women, or the number of SIR members who are women, increased from 6% to 13% between 2008 and 2017. And that increase is also borne out among our trainees. So the resident and fellow section grew from 11% women to 16% women. But vitally, the increase in representation and leadership at the level of annual meeting speakers, executive council members, first authors and senior authors in JVIR have really created the infrastructure, or starting to build the infrastructure, for a more lasting increase and sustainable increase in women in IR. And those numbers are all from a paper that was put out by Dr. Kohi and her colleagues at UCSF. Moving on to the specific considerations of the COVID-19 pandemic, here in New York, it's definitely rocked our world. And I know that We've been a national and global epicenter, I guess a dubious distinction. Our hospitals were all running at 150% or more capacity, with the majority of those patients being COVID positive or under investigation. And it's an ongoing and cataclysmic health event. It's a defining period for a whole generation of doctors and really raises the some major considerations of altruism and personal risk in the setting of many unknowns and rapidly changing data, rapidly changing recommendations for safety. It's ongoing and evolving. We're talking about second waves and third waves. Really, even though in New York right now, our numbers are on the decline, in many parts of the country, the rate of infection is rising. And so our practice really needs to consider that for the near future, we'll have to take COVID-19 into account. In terms of terminology, I tend to say COVID or COVID-19. Something you may also see in publications is SARS-CoV-2. These are all really interchangeable. Looking at the specific risks to women from the pandemic, there's a critical paucity of data. Really, it's only been about 6 months since this disease was even identified. And as one can imagine, the areas that have actually the most data, the most cases, have also been the busiest clinically. And so it's actually astonishing that the literature has caught up as much as it has even, but there's certainly still a lot of data that has yet to be shared publicly. Overall, women are less likely to become seriously ill than men, and at least in the published cohorts that we have, the rate of death in men when matched for age and comorbidities is more than double the rate of death in women. However, there are some early and concerning data that do suggest that pregnant women particularly may be at greater risk of serious illness. Again, the knowledge is really limited because we're so early in this experience. This disease hasn't even really been identified for the length of a full gestation. Case reports do describe some severe cardiopulmonary complications and other adverse maternal outcomes in late pregnancy. Data on early and mid-term pregnancy are still quite limited. Studies from China and Spain reflect about a 10% rate of severe adverse maternal outcomes in women with COVID-19. And there's a study that's frequently cited from SARS, the original SARS from the early 2000s, which showed that there was a 25% mortality in pregnant women versus 10% in the general population. That said, if you drill down and you actually look at that paper, the N is 12 and all those patients were symptomatic. So it's difficult to know how much to extrapolate there. And in a letter to the editor from May 2020 in the New England Journal of Medicine, Columbia Medical Center screened all of the women coming in to deliver for COVID at the peak of the New York outbreak. And almost 88% of the women who tested positive were asymptomatic and had no complications. So putting, again, all of this kind of sparse data together, really what we're saying is that there is a real risk. It merits consideration, but probably these outcomes are far more rare than not. The risks to the fetus or to neonates is also unknown. There's at least one pathologic study of placentas in patients with COVID-19 after delivery that show that there are maybe an increased incidence of vascular or thrombotic events in the placenta that may correlate with complications, potentially preterm birth. Symptomatic infection in infants and small children seems to be rare. However, now there's these cases of multisystem inflammatory response syndrome in small children, which may reflect a delayed impact. And as an added stressor, some mothers testing positive for COVID-19 have even been separated from their infants after birth as a precaution. Something that Teresa Caridi really expressed eloquently in the Thursday RSNA session is the dueling responsibilities that are really faced by pregnant practitioners, pregnant doctors, where they want to take care of their patients, they want to not abandon their colleagues, and they want to be good team players, but they also feel a responsibility to themselves, to their unborn child. And this can really lead to cycles of guilt and exhaustion and burnout. And so really what's most important is that as colleagues, we're aware and supportive of the difficulty of this particular situation. So looking at solutions, essentially any patient care is going to confer some risk, even with rapid testing. Our current testing has pretty poor sensitivity, and there's a high proportion of asymptomatic and pre-symptomatic patients. It's unclear how contagious those patients are from current data. So really, risk avoidance, does that mean avoiding all patient care? Potentially, and ways that certain practices could achieve that is by reassigning pregnant women to diagnostic radiology, potentially even teleradiology, in an all-IR practice, doing virtual patient care and consults, clinics, et cetera, could provide another protective mechanism. What's probably more realistic is risk mitigation. So trying to utilize rapid turnaround testing. We get our results now in a couple of hours on site. And again, the accuracy is not great. We do have a relatively high number of false negatives, but it at least allows you to screen patients to a certain extent. In some practices, pregnant practitioners are avoiding contact with patients who have active proven COVID-19, as well as patients under investigation if they're pregnant. Whether that's totally possible in a shared on-call pool or in a cohort model where a team may not have more than 1 or 2 IRs, it's questionable if it's totally possible. But again, a decrease at each of these levels does help mitigate the risk. And then finally, something that I would say from certainly our perspective as an area that had a very, very high incidence of COVID-19, we're full PPE for all patient care, whether or not the COVID test is negative. We wore N95s, face shields for all patient interactions. The issue is that as the patient population has a higher incidence of the disease, the false negative rate becomes much more significant. So it's just something to bear in mind that, it's uncomfortable, but it may be the safest way to proceed. Moving on to other dimensions of health, psychosocial health, work-life balance. Numerous studies have shown that women across all professions, across all medical specialties, and also specifically in IR, tend to bear more than 50% of childcare and family care responsibilities in opposite sex couples. Those responsibilities have increased in the pandemic situation with schools being closed and homeschooling and educational activities being monitored by parents, loss of daycare and in-home care for children and for elders, and the absence of play groups and activities. The solutions here are going to be different for every situation. I think the most important is to acknowledge that there's an issue or maybe an issue, open a dialogue with colleagues who have young children or elderly relatives that they care for, parents. Some solutions may include flexible or alternative schedules, like shifting the weekend or creating early or late shifts to kind of dovetail with a co-parent schedule, and potentially minimizing virtual meetings when possible in favor of email. Finally, last dimension we're going to look at is professional health and professional advancement. Many studies have looked at the pre-existing gender gap in academic productivity, the falling off, the gender gap that kind of grows over levels of promotion in academic tiers. And that pre-existing gender gap has been attributed in part to the greater home responsibilities borne by women over time. The gender gap in publication has been demonstrated to be growing during the pandemic with a publication in Nature that showed decreased, it's in preprint, but it's available online, decreased submissions by female authors in March and April of 2020 versus in the previous months. And then there's a particular discrepancy in COVID-related research, which to me basically reflects new work. So again, people may have been submitting work that had been previously completed, but the new work shows a really large gap. And then those are academic considerations, but looking at kind of private practice considerations, our view discrepancies may increase if a mother has greater responsibilities at home now. Some solutions to this from the academic standpoint, extending the clock for promotions, extending deadlines, I think is important. Looking at candidacy for alternative paths to promotion via other contributions to the department and the institution, which often are disproportionately taken on by women, like service type academic obligations. And then again, potentially directing additional resources such as research assistants, trainees, and students to interested female research mentors to help even the productivity gap. I think it's important to think about the productivity gap, not just in terms of making the numbers look better, but also potentially losing out on the insights and scientific contributions of a large proportion of the medical community. And then in terms of private practice, again, I think it's a little bit tougher, but considering alternative assessments of contribution and value to a group versus a pure RVU model may help avoid growing discrepancies in compensation. So just to wrap things up, again, the first big thing is just awareness. I think identifying that this may even be an issue, particularly as the number of women in IR grow and we want it to continue to grow. Just recognizing that they may have different concerns in this kind of multidimensional assessment of health, both personal, physical, psychosocial, and professional. The biggest, I think, commonality between all the solutions that suggested is really flexibility and talking to people about what may help and what may allow them to achieve their greatest productivity and health. And just being supportive. It's a very difficult time. It's really an unprecedented time in contemporary medical practice, and we all need to be here for each other. Thanks for your attention. These slides will be posted, so you'll get all these references there should you like them. And that's it. Thank you so much for your attention.
Okay, thank you, Divya. I'm just gonna go on from here. So I'm Maureen Cohey, and I'm the Chief of IR at UCSF, and I'm so excited to talk about one of my favorite topics, which is fibroids, but I really wanted to focus on the things we've learned in the last 25 years since UFE has really been around, and what are some updates that we should be aware of with respect to the literature. So these are my disclosures, which are not related to the presentation. So with respect to the outline, I wanted to touch on some of the technical advancements or changes that have come in our way. Then I wanted to highlight some new information we have with regards to the outcomes, which I'll just tell you are excellent, of this procedure. And then talk about the fertility, which is a common issue that we have with our referrings and some patients with respect to UFE. And then discuss some fact versus fiction topics with respect to patient selection. So in terms of technical advancements, really what we're thinking about here are embolics and the access, the route of getting into the artery, and then some peri-procedural care updates with respect to how to make this what people consider to be an excruciatingly painful procedure less painful and much more pleasant for our patients. So it's been a long time since 1995, right? So this was the original paper by Ravina et al. Who discussed the findings of embolizing fibroids is actually a possible thing. And back then, the only material on the market, the only embolic, was PVA. And so we've certainly come a long way. As you can see, we have trisacral gelatin microspheres in addition to PVA and a number of other embolics. So I do want to point out gel foam, right? So if you look at the Asian literature, specifically the Japanese literature, excellent results with a very cheap embolic. The only problem with it is the reproducibility in terms of the size. The way that I cut my gel foam is probably different than the way other people cut theirs. But I just want to point out that these two, so trisacral gelatin microspheres and PVA, are the only ones that have been compared in a prospective randomized controlled trial and have shown to be non-inferior to each other. So if you're following evidence-based medicine, comparative trials is what we want to look at with respect to outcomes. The other trials have shown safety and efficacy, but in single-arm trials, there is a trial that's ongoing comparing embazine to trisacral gelatin microspheres, or embospheres, and the results of that should be out hopefully in the next year or so. With respect to access, so this is a really fun topic because these are, great friends of mine. The transradial approach, right? Not just for UFE, but for all things we do in IR. But the main point of why we do it is for patient comfort and preference. The fact that these women after the procedure don't have to lie flat and supine, and they can be in the fetal position or on their side is very helpful. And also maybe it potentiates same-day discharge. And this idea that of which was truly pioneered by the Mount Sinai folks, and there's a treat symposium that covers multiple aspects of transradial access. Also touches on the fact that it's a safe and effective treatment, and with respect to UFE talks about the fact that it does improve patients' quality of experience after the procedure. So something to think about if in your procedural regimen. With respect to the other things that we talk about are the peri-procedural care. So the things we can do before, during, and after the procedure to minimize the pain, the post-embolization pain, the post-infarction pain that the patient feels. And so this is a relatively new study that was presented as an abstract many years ago at SIR, but essentially looked at a double-arm comparative trial, randomized, double-blind, sham-controlled, with respect to a superior hypogastric nerve block. And the study demonstrated that when you do a nerve block, which is what we commonly believe, it is effective. So it's effective in decreasing pain, it's effective in decreasing the dosage of analgesia that the patient gets, and the complications are essentially not really too significant. And so and multiple other studies, recently a study also published in JVIR, have demonstrated the safety, efficacy, and utility of doing this procedure. So something to think about if you're clinically up for the task of doing this. Another great study came out of South Korea, and this is Man Kim's group, where they prospectively evaluated in a double-blind placebo-controlled study the pre-procedure administration of steroids. Now, this is something that if you talk to an anesthesiologist, they say, well, why don't you do this? Or if you talk to interventional oncologists, they talk about the fact that you should do this before all TACE or other embolic procedures. So why aren't we doing this in UFE? And in this study, what they did is they randomized the patients and they looked specifically at inflammatory markers. And they found that the inflammatory markers, along with the pain, severity of the pain decreased after the procedure in patients who had gotten the pre-procedural steroids. So I'm a big fan of this, by the way. Another study, which is very self-explanatory, is the fact that I have like hair everywhere, is the fact that if you give long-lasting opioids before the procedure, then maybe it'll improve the patient's post-procedural pain. I mean, it makes sense, right? So instead of giving fentanyl, which is very short acting, if you give long-acting painkillers, then by the time the patient finishes the procedure, then she's already set up nicely, as opposed to always playing catch up, which was really the outcomes of this trial, which really argues about the administration of long-acting opioids for the treatment of fibroid embolization. What can we do in the procedure? Well, this is a really great study that was published in JVIR a couple of years ago. It had 3 arms. The patients were randomized to either get intraarterial lidocaine after the embolization, before the embolization, or none, so a sham. And what the authors found that if you administer intraarterial lidocaine after the embolization endpoint, the pain score in the short-term phase is much lower. And this is important to make sure not to inject lidocaine before embolization, as commonly we do in the hepatic artery, for example, because in the uterine artery it can cause spasm, and that was demonstrated many years ago by Jim Spies. So with respect to outcomes, I mean, we all have a sense of this because we believe that this procedure is really amazing, but how are we going to intelligently articulate that to our referrings and our patients? Well, I think the things that matter are with respect to long-term clinical success, the complication, and the reintervention rates. So we're lucky because a Cochrane review was performed for all the evidence that's out there with respect to UFE. And this really took a deep dive into all the papers, and really high quality papers have been written with respect to UFE over the past 25 years. And what they found was the satisfaction rate after UFE 2 years after was about 50%. And you know, that really does take, it may not sound so high, but that does take into account patients from a variety of ages, which may also affect reintervention rates and recurrence. Definitely shorter hospital stay, rapid return to work, almost very few days lost of work, higher risk of minor complications. This is just the bleeding and the bruising, potentially return to the ER, but very lower rates of more advanced adverse effects. The thing that I'm really excited to share is the 10-year outcomes of the EMI trial. Now, the EMI trial was the original trial that compared uterine artery embolization to hysterectomy. And 10 years after, we got a good number of patients who answered the questionnaire, which 84%, which, you know, if you've ever done surveys, that's a ridiculously high number of patients. And what they found was that about 2/3 of the patients who underwent UAE didn't need to undergo another intervention, which is really remarkable, right? So you kind of have to take this hand in hand with that 50% satisfaction, because when you look at it in the long term, they found that the patients did very well. And in fact, and this was published in an OB journal, they said that just about anybody who is being counseled for myomectomy or hysterectomy should also be given the option of uterine fibroid embolization, which I think is really striking that we've made this much headway into the OB journals. So these are the usual complications that we talk about that I talk about with my patients. And I think the main part that I really focus is the permanent amenorrhea, so the ovarian dysfunction. And it really is age dependent. I can tell you that I've hardly seen this occur in anyone younger than 45, but it does happen in someone older than 45. And there's definitely great papers written about the different communications between the fibroid and the ovarian, the Razavi staging classification that really does tell us that, you know, the particles may end up in the ovarian artery, and if the ovaries are not as robust, then maybe that's a hit that could be potentially resulting in early menopause, and something to discuss with women. And for the most part, I could tell you a woman in her 50s is not shocked about menopause. I mean, it's around the corner, but best to discuss that in the pre-procedural clinic visit. And the rest of the complications are very rare. So here, with respect to our outcomes here, what we're talking about is again, analysis of reintervention. So how do we do with respect to our long-term reintervention after UFE? And you can look here and you can see that when you compare it to myomectomy, as I've just shown you with respect to hysterectomy, the rates of reintervention for UFE are higher. But then you look at other things such as HIFU, which is a non-invasive procedure, then the rate of reintervention is lower. So certainly we don't do as well as myomectomy because, you know, we're not removing the fibroids, but also it's again around that 15% range and very long-term outcomes. And again, this is the forest plot essentially showing the myomectomy and UAE have similar reintervention rates, but for UAE, it's higher definitely and much better when compared to HIFU. Let's move on to fertility. Now, I don't know about you all who do fibroid therapy, but this conversation happens a lot. And it happens when I give grand rounds or when I talk to gynecologists, because they're really worried that if you do UFE, then fertility is over. It's not even an option. And I'm like, no, that's hysterectomy. That's not UFE. So what we we're battling is this one trial, the only prospective randomized controlled trial out there, which compared patients who wanted to preserve fertility, who were randomized to UAE versus myomectomy. And they looked at a variety of different things. And this was from a long time ago, really. And you could see that, and I could tell you that the patient populations were very similar. And as expected, the procedure time for UAE is much shorter than for myomectomy. But you can see with respect to just about every outcome variable, it favors UFE, whether it's the recovery or the disability, but with the exception of reintervention rate. So again, something that we struggle with compared to myomectomy. But what I need you all to understand is that about a third of these patients in the UAE arm also underwent a secondary procedure. Now, why is that? Well, in the study, the design, the investigators said that if there was not enough shrinkage of the fibroid at 6 months after the intervention, then the patient should undergo a secondary procedure. And so what this meant was a third of the patients who underwent UAE also underwent myomectomy. And what we found out with respect to pregnancy rates and delivery rates was that there was a statistically significant difference favoring myomectomy compared to UAE. But you have to understand that they looked at these outcomes for 2 years, and the clock started after the patients finished their last procedure. So the patients who underwent myomectomy were able to conceive and they were able to deliver, whereas a third of the patients who underwent UAE, who had to undergo myomectomy, had a fewer amount of time to hit that 2-year mark where they completed the study. So lots of confounders, not a great study, but the results of it in the conclusion is that myomectomy has a superior reproductive outcome in the first 2 years. So again, very important to really do a detailed deep dive of this study. And then when you look at a more recent study where there was a systemic review of looking at all sorts of papers that have been published, what the authors found out, and as I'm showing you here, you can see there's only one RCT and several case series. The conclusion is that there's a low quality of evidence. So we really don't know for a fact what to do with respect to fertility and UFE and myomectomy. And again, multiple other recent public literature again demonstrate that the outcomes in terms of the studies favor myomectomy, but the quality of data is poor. And again, I have just a bunch of papers here just demonstrating that even though we're saying that myomectomy versus UAE, myomectomy has slightly better outcomes, the outcomes of fertility after UAE is very similar to that of the normal population. Always good to go back to our society's recommendations. These are from the guidelines that were published several years ago, but basically what it says, the way I practice is I always, make sure that I talk about fertility with a patient. And if she has an anatomy that favors myomectomy, if she's got a small fibroid, it's fairly anterior and would be a very easy surgery, then why not? If she doesn't mind surgery. But if the patient prefers a UAE, then you just have to review the data and let her know that ultimately we don't have the level of evidence to make certain whether it's one way or another, and that we're just trying to do the best we can, and ultimately it's her decision, and that's the best way of offering patient-centered care. Lastly, I want to talk about some fact versus fiction. This stuff still comes up, even though I think that we've addressed it very well in the literature at times. So a couple of things I've heard, some starting with can't do a UFE if the patient has an IUD. You certainly can't do a UFE if the patient has big fibroids. You certainly don't want to do UFE if the patient has any intracavitary fibroids, and all fibroids are benign. So you kind of know where we're going to go in the next few slides here. So this was a good study that came out about a decade ago now that shows that in a small population of patients that having an IUD did not impact the outcomes of the study in terms of complication. So, and I could tell you that in my practice and in a few of my friends who do UAE all the time, having an IUD is not a contraindication. So don't make her have to remove her IUD in order to put it back in because really there aren't any increased risks of infections. What about large fibroids? I think you can UFE as many fibroids as you can. The problem is the post-embolization pain that I've seen. So, and also you need to manage the patient's expectations. So I tell this story a lot that I had a patient whose uterus was at her xiphoid process. So she had a very distended abdomen and she wanted UAE because she wanted, a flat abdomen. And so that's going to be hard, if not impossible, right? Because at most you're going to reduce the size of the uterus by 50 or 60%, and that's not going to, that's going to bring it to a 24-week uterus at the umbilicus. So managing the expectations is important. But if she is okay with that, or if she's not concerned about that, then I think based on the literature, you can perform UFE on very large volume fibroids. But again, it's managing the post-procedure expectation and the pain. Intracavitary fibroids, I take this very seriously. You having a good close relationship with your gynecologist is very important, because if the patient has a bunch of intracavitary fibroids and she's bleeding and she's presenting with menorrhagia, maybe the best answer is hysteroscopic myomectomy. But if she's got a couple of fibroids that are in the cavity, but a bunch more everywhere else, and she wants a UFE, then you just, again, have to manage her expectations and let her know that in a month or a couple of months, she could potentially pass these fibroids. And depending on the size of them, they could get incarcerated, and she may need to come in for removal. The worst thing you want is to not talk about this with a patient, and then she goes into the community, and in a month or 2 months, she passes them, or she tries to pass the fibroids, and then she gets super infected, and then she goes to the GYN, who has to do a hysterectomy or a myomectomy, and there's infection, and there goes your referral. So, and it's really bad for the patient. So again, having an active conversation before the procedure is important. With respect to leiomyosarcoma, I mean, this was a big deal back in the day when all the papers were writing about it, but really a really small chance, right? So less than 1% of women with fibroids have leiomyosarcoma. So a very rare entity. So the quoted rate is about 1 to 350 to 1 in 1,000 or less. But again, something that there's no imaging manifestation, there's no labs that we could do to test for it. So something that you need to discuss prior to the procedure, that this certainly could be existing in one of the fibroids, but the chances are extremely unlikely. And if she, and again, it's the risk averseness of your patient, and if she can't, she's uncomfortable with that, then I think hysterectomy or myomectomy is the better solution. So basically, can't UFE, that's definitely, with an IUD, that's definitely false. Can't UFE with big fibroids, definitely false. Can't UFE with intracavitary fibroids, maybe, right? You kind of want to have a discussion about this and see how your gynecologist feels about that. And all fibroids are benign, well, that's certainly false. So I just wanted to wrap up with just a couple of my, thought process when I come up with when I go to see patients for UFE. So here you have a patient who has a number of fibroids in her uterus, but she has no symptoms. And this happens, right? About 50% of patients with fibroids don't have any symptoms. But for whatever reason, she got herself an MRI. I don't know why, but she has fibroids and she wants to do something about them. Should you, as the interventional radiologist, do something about that? Well, I really believe that the most important contraindication is no indication, right? You don't want to cause harm when there was nothing to fix. So I think something to think about as we become, as IRs move closer and closer towards being, real clinicians and having a clinic and seeing these patients, these discussions are paramount. You really need to have an understanding of what her symptoms are and what her menstrual history is, what her pelvic symptoms are. I mean, does it really explain what's happening with respect to the fibroid? Really important to touch on that fertility. Some insurance companies will not pay for UAE if you don't have a clear line in your note saying that she doesn't want fertility. And lastly, I'm a big believer in MRI, contrast-enhanced MRI, because I feel that it's important to make sure that not only does she have fibroids, but that her fibroids are actually explaining her symptoms, right? If she's presenting with, irregular bleeding between periods, that may not be because of her fibroid, it may be because of cervical cancer. Or if she's got a lot of bulk and pressure, and she has a little tiny fibroid, but her main issue is adenomyosis, you can still do UAE, but you got to change your particles, and you have to also educate her with respect to post-procedural outcomes. And then again, pelvic discomfort is a very common thing in women. And it's not always because of fibroids. And lastly, I already told you enough about the intracavitary fibroids that really comes across nicely with an MRI that can help you manage your procedure and also her expectations. And lastly, always look for that ovarian. And if you do nice MRAs, you can see the ovarian artery that plumps up on the MRA that's supplying the fibroid that you would have missed if you hadn't looked for it or hadn't done an aortogram. And that definitely does affect your clinical outcomes and clinical success. A last word about contraindications really haven't changed since the SIR guidelines were published. And in conclusion, I just wanted to reiterate something that we all know, that UAE is safe and effective for the treatment of symptomatic fibroids. Very low complication rate, low reintervention rate. And again, like everything else we do in IR, patient selection is key. And it kind of makes you wonder, well, why aren't doing more of these, right? Why is hysterectomy the #1 treatment for fibroids in America? And I think the reason is outreach, right? Which is why all the efforts that our society is putting in to connect with patients and teach them about our new procedures and our minimally invasive approach is so important in order to get these patients to have a full understanding of all the minimally invasive procedures that we can offer to them. Okay. Thank you so much for that. And I'm just gonna go right forward and introduce Dr. Meredith McDermott, who is going to talk about uterine artery embolization for adenomyosis.
All right, thank you so much. Let me just get my screen shared here. Okay. All right, so hello, everybody, and I'm going to kind of stay on the embolization train here and talk a little bit about UAE for adenomyosis. No financial disclosures. So I wanted to start with just a little bit of background. Hopefully this isn't too basic and it can just be a nice refresher for everyone. So as I'm sure most of you know, adenomyosis is defined as the presence of endometrial glands and stroma within the myometrium. It's not exactly the same thing as endometriosis, but I think a lot of people think it's sort of along the same line of disease process. And as a little bit of an aside, I'll just say that's how I often describe it to my patients, because I think if you take the average woman in off the street, they've heard of endometriosis, but no one has ever heard of adenomyosis. So I think it's a good way to kind of help them conceptualize what's going on in their bodies. So now this ectopic tissue results in enlargement of the uterus because it causes the normal myometrial cells to hypertrophy. This ectopic tissue can be diffuse throughout the entire uterus, and you can also get sort of focal areas within the myometrium that are really sort of mass-like, in which case we'll often refer to those as adenomyomas. In terms of the exact pathogenesis, we don't really know. I think the most accepted hypothesis is it's just direct invasion of the endometrium into the myometrium. And when we think about some of the risk factors for adenomyosis, that does make sense. So especially things like parity and prior uterine surgery, right? Those are things where that normal boundary between the endometrium and myometrium might be affected. These patients are going to present very similar to patients that you see with fibroids. So again, they're going to come in with abnormal uterine bleeding, really heavy periods. They often will have dysmenorrhea and pain. They can have dyspareunia, and even a certain percentage of patients can have non-cyclical chronic pelvic pain. In terms of the demographics, we don't actually know a lot about the true incidence and prevalence of adenomyosis. This is because classically this diagnosis was only made on pathology after a woman had already had a hysterectomy. I think nowadays our imaging is very good and we're all very comfortable prospectively diagnosing women based upon imaging with adenomyosis. So now finally in 2020, all these years later, we finally have a study that was published this year in the American Journal of Obstetrics and Gynecology. This was a large population study in the Kaiser system in Washington state, and they found that the annual incidence of adenomyosis is somewhere around 1%. In terms of demographics, it's actually very similar to our fibroid population, right? So the highest incidence is in women in their early 40s and also in non-Hispanic Black women. And another interesting thing that they looked at was what is the rate of concurrent pelvic pathology? And it's very, very common. So almost 50% of women will also have coexisting fibroids. And almost 20% are also going to have endometriosis. And I think that's sort of an important point, and I'll talk about some of this. I think that doing research on adenomyosis is difficult, and I think this is one of the reasons that makes it difficult is this other pelvic pathology is so common that it can be a little hard to really suss out what is causing the patient's symptoms. Is it the fibroids? Is it the adenomyosis? Is it the endometriosis? And I think it's also just really important as a clinician to be aware that your patients may have these other conditions, especially something like endometriosis, and they're having a lot of dysmenorrhea, and they're hoping that the embolization will help them, it might not, because it's not really going to do anything for the endometriosis. So I think it's important for you to know and for the patient to know when they have some of these other conditions going on. So I'm going to kind of skip a little bit over ultrasound just for sort of brevity's sake. I'm definitely similar to Maureen. I'm a big believer in MRI. I get MRIs on all of my patients. If you are interested in the ultrasound diagnosis, there's a great radiographics article from 2018 that you can pretty easily find. But I think that especially in the US, we're a little MRI heavy, and if patients are going to get to the point where they are seeking treatment, they're probably going to get an MRI. And I think the MRI has the benefit of really better defining exactly what's going on. It can clue you into some of that other pelvic pathology. And I think one of the difficulties with ultrasound is when you do have a focal area of adenomyosis, it can sometimes, I think, be a little tricky to know, is that an adenomyoma or a fibroid? And the outcomes are a little bit different, which I'll get to, so it's important to know that. So on the pre-procedure imaging on your MRI, the most important, the important thing you want to look at are the T2 weighted images. So what we're looking is at the junctional zone. So that's sort of that area right along the border between the endometrium and the myometrium. And the classic definition is that this junctional zone is thickened greater than 12 millimeters, and that's consistent with adenomyosis. Obviously, it can be sort of much thicker. So in this case, the adenomyosis is extending into the anterior wall of the uterus quite a bit. And you can also have much more dramatic cases of adenomyosis. So this is another example of a different patient, and the entire uterus is really kind of globular and expanded. All these little sort of T2 bright areas or just ectopic endometrial tissue within the uterus. And then this is sort of my second point about studying adenomyosis that makes it different. So, right, this is the same disease process, but these two images look very different. I think that people are trying to come up with ways to sort of define and categorize adenomyosis on imaging, but I don't think that there has really been a way that the diagnostic radiologists have really agreed upon. So then it makes using your imaging to maybe give a prognosis for a patient, how well they might respond to an embolization, it makes it difficult. Some of the things that have been studied are the thickness of the junctional zone, and also the signal intensity may have an impact, but I think those are sort of relatively small studies, and I don't think that we can really draw any firm conclusions sort of just based upon that. So I'm going to kind of jump into UAE for adenomyosis versus fibroids. So Maureen did a great job kind of talking about all the fibroid related stuff. So I'm just sort of going to focus on how embolizing adenomyosis is a little bit different compared to fibroids. So I think one of the big points is that the blood supply to adenomyosis is going to be a lot less well-defined. So in fibroids, right, we're targeting that perifibroid plexus, which is a very kind of large capillary bed. These are large masses, whereas adenomyosis is a much more invasive process within the myometrium. So you're really targeting the myometrium itself. Because of that, you do have to start with a smaller particle size to start. And this is maybe something where everyone might be a little bit different with how small they want to start. But for example, you know, if you're using TGM microspheres, I usually start with maybe 300s to 500s versus 500s to 700s. In the case of non-spherical PDA particles, and that's referenced below, there's a great paper from Dr. Kim with his 1-2-3 method. So starting very small with a non-spherical PDA and then working your way up, and he had great results from that. And I think sort of maybe the point is you shouldn't be afraid to start with these smaller particles. There's never been any evidence that there's a bigger increase of complications, such as like myometrial necrosis, by using these smaller particles. And then I think sort of along the same vein is you probably want to embolize to a greater stasis compared to fibroids. Because this is a more invasive and kind of difficult process to treat, instead of maybe embolizing to 5 to 6 heartbeat stasis, I'll go something more like 9 to 10 heartbeat stasis. So what about outcomes? So we don't really have any randomized controlled trials for adenomyosis, and I think that's going to be a difficult thing to do just because it's not quite as common as something like fibroids. So what we're left with is just a lot of kind of small to mid-size retrospective studies and prospective cohorts. So instead of going through every single one, I thought I would just sort of talk about this paper. This was published in JBIR in 2017, and I think it's the biggest meta-analysis that we have looking at UAE for adenomyosis and kind of probably the best collation of data. In the end, they ended up with about 30 different publications and a little over 1,000 women. And I'm going to focus really on the long-term outcomes because I think, you know, if you're going to do something that's only going to help someone for 6 months, that's probably not super useful. So kind of looking at these long-term follow-ups, about almost 3/4 of women continue to have symptomatic improvement in the long term with about a 7% hysterectomy rate in pure adenomyosis patients. And then patients with combined adenomyosis and fibroids, they did a little bit better in terms of the symptomatic improvement, so 85% in long-term follow-up, but with a similar hysterectomy rate. So what do we do with this information? You know, these patients don't have a lot of options. So when a patient has adenomyosis, really their only option if they fail medical therapy is going to be a hysterectomy. There are some papers out there in the gynecology literature of other surgical methods. So they do things like trying to remove the adenomyomas. They'll do actually myometrial resections, but the data is very bad. So they have like a 50% or less success rate, and it seems like a pretty invasive procedure to do. So I think if you have a patient who wants to preserve their uterus, and maybe because of childbearing or for whatever reason, I think that this is an excellent treatment that you can offer them. And again, it's counseling, it's having that conversation with them about what their chances of symptomatic improvement are, what their chance are that they're going to need another procedure down the line. And as long as everybody's on the same page, then I think you should be totally comfortable treating these patients with embolization. Okay, so just to show a real world example of a patient I've seen. So this was a woman I saw a couple years ago, 40-year-old. She had really, really heavy bleeding, requiring multiple admissions and transfusions. You know, she's young. She still had some interest in future childbearing. She really didn't want a hysterectomy. So she came to me and we did a bilateral uterine artery embolization. I just listed my particle sizes just for people to get an idea, right? I started a little bit smaller than I normally would for a patient with fibroids. And then this was her 6-month post-procedure MRI. So this was really dramatic results, right? I mean, her uterus is so much smaller than it was pre-procedure. There's obviously sort of this big necrotic area of adenomyosis that's been treated. And I believe she's now just a little over 3 years out from her procedure. And although I'm not actively seeing her, just kind of doing some chart stalking, she's still doing really great. No more symptoms from her adenomyosis. So just to kind of summarize, you know, adenomyosis is not a super well understood clinical entity, but despite that, it really does result in significant morbidity. You know, these women, similar to the fibroid patients we see, they have such heavy periods, they can't even go to work. So it's very impactful on the individual level, it's impactful on a societal level, and a hysterectomy is really their main option. And I think that's sort of unfortunate for them that that's really the only treatment they have traditionally been offered. So I think that although the existing data we have on UAE is not perfect, and it definitely is maybe a hole in our literature, you know, as a profession, I think what we do have is very encouraging. I think it's good enough that you can be really comfortable treating these patients with embolization, with proper counseling. I mentioned that, and I just to kind of go back, I do think there are some potential barriers. I think to get a really good study, it's going to definitely have to be an effort amongst many institutions, and hopefully something that we can do in the future. So I think that is it. So all of my references are listed if you want to check out any of those. And that's all. Thank you.
Thank you for that fantastic talk, Dr. McDermott. We really appreciate you joining us for this. Our next speaker is going to be Dr. Janice Newsom from Emory University, and she will be speaking to us about peripartum hemorrhage, including some very exciting new developments. So thank you for joining us as well, Dr. Newsom.
Who is my secret surprise at the end. I want to thank the organizers. I'm going to make up some time here because I can talk really, really fast. So let's go for it. So I have no disclosures. I don't think I will in the past. My only disclosures is that I've been a part of SIR for over 25 years and I love it. I also must disclose that I work with some of the brightest people, and I want to thank my partners and the APPs, the trainees, the administrators that allow me to continue to do my work very well. And some of them are on right now. Thank you very much. So having a baby is usually a happy time for families, especially for moms, but for a growing number of women in the US, this is not the case. Childbirth can be one of the deadliest times for moms. And in recent months, there are several stories about women that are dying from seemingly uncomplicated pregnancies that have been covered in the media. But I can tell you that that doesn't even tell the story. 2 out of 3 women die every day in the United States from complications while they are bringing life. A shocking statistics if you consider that most of these pregnancy-related deaths could have been preventable. The United States is ranked 47th in the world for maternal mortality, and in 2015, the Global Burden of Disease study revealed that for every 100,000 births, that there are 26 mothers that would die in the US, in comparison to deaths of 9 in the United Kingdom, 7 in Canada, 4 in Italy, Sweden, and Denmark. It is time for us to sound this alarm. In addition, there are significant racial and ethnic disparities in pregnancy-related mortality. African-American women have 3 to 4 times more deaths than all other racial ethnic groups combined. According to the American Health Rankings, there are a 20-point gap between white and Black mother deaths rates during childbirth in the United States. 8 years ago, the human rights organization Amnesty International declared that maternal health crisis in the US and said that Georgia, the state that I live in currently this year, has the highest maternal mortality ratio in the United States, a finding that I personally find outrageous and absurd given that I live here. According to the CDC, the rate of postpartum hemorrhage and blood transfusion has recently noticeably increased over time. A review of the Joint Commission Sentinel Events database for cases coded as maternal death or severe maternal mortality for 2010 through 2019 indicates that maternal hemorrhage is a causal factor in over 50% of all of these reported Sentinel events. Now, this is a particular patient safety concern, and that's why in July of this year, Joint Commission has introduced 2 new standards addressing these complications of maternal hemorrhage and hypertension and preeclampsia are 2 of these things that the Joint Commission is addressing so that we can actually get a handle of this. Rates of peripartum hysterectomy in the United States have gone up substantially from 1994 to 2007, and they believe that these rates may be due to the increase in rise of C-sections. So let's get to some definitions. Postpartum hemorrhage is defined as blood loss of more than 500 units after vaginal delivery or more than 1,000 cc's after C-section. And that was like this arbitrarily assigned values, which we now know have been problematic. In our hospital, we just use a liter, whether it's vaginal or C-section. And we know that there's several studies that have shown that our ability to estimate our blood loss is dismal. Recently, there was a study that was done by ER doctors, and that's why that white t-shirt is there, that says that we tend to overestimate when there's a small amount of blood, such as someone that comes to the ER with a nosebleed. And we tend to underestimate when there's a large amount of bleeding. So this blood volume issue is really problematic. Postpartum hemorrhage, though, anybody that has any significant blood loss that deals with hemodynamic instability is adequate for the diagnosis of postpartum hemorrhage. And this, again, is very, very subjective. Therefore, the management of this condition must be urgent. It must be simultaneous intervention must be initiated. So a high index of suspicion and vigilance is mandatory. So by the time we start seeing hypertension, tachycardia, dizziness, and pallor, this mom has lost 20 to 25% of their blood volume. Moreover, we know that these changes in the vital signs can be very subtle, as these initial stages of hemorrhage in young women, they can compensate for a large amount of volume loss before then they're just crashing. So pregnancies beyond 20 weeks of gestation can be at risk for postpartum hemorrhage. And there's several factors that could cause this, but I want to warn you that this could happen without any warning. Here are these 4 T mnemonics that can be helpful for remembering what are these causes. And so tone, which uterine atony that could happen from prolonged labor, happens to be the majority of them. And you can read as fast as I can, and I'm only going to show a few cases of tone and tissue really abnormal placentation, but you can see some of these other causes here. So remember that there's a well-developed algorithm by the OBGYN community as to how to deal with this. So after initial resuscitative efforts by manual, fundal massage, and uterotonic drugs, if there's continued bleeding, then that's when we get the phone call that, oh, by the way, my patient is in trouble and is IR available? Can we really do something? Embolization for postpartum hemorrhage was described in the literature in 1979, and the authors described a case there where all local measures had failed: transabdominal hysterectomy, hypogastric artery embolization. That all failed to stop this life-threatening bleed, and gel foam embolization with pledgets resulted in immediate cessation of the bleeding and subsequent stabilization of the patient. So this is not new, and embolization remains the mainstay for today. So I want to go through this case kind of quickly, and I know that you can go to our references at the end. So just to make up some of the time. So this is a 36-year-old reality star TV show host who is a personal friend of the OB. This is her first of 3 babies planned, you know, because we're modern women, we're planning everything now. And this was a highly anticipated birth. All until things didn't go well and she needed an emergency C-section. There was some difficulty in closure, the patient got cold and boggy, and then just would not stop bleeding. Then we were called to IR after lots of panicking. Is someone please available? Can you please stop the bleeding? So of course, this patient was able to have, I don't know if you can see it here, we were able to get into the left uterine artery, and it is not often that you always see the points that are bleeding, but in this case, it was certainly a lot of bleeding, and we were able to embolize with gel foam. I'm going to show this to you in another case. Don't worry if you've missed it. So the patient didn't quite get better right away. And so the very next day, they got another CT scan to see if we missed another site. And you can see that there's that retained contrast where we had like active extravasation from that left uterine artery. And within another few hours, the patient did great. They were just so far behind from their blood loss, people were a little concerned. So the contraindications for uterine artery embolization for postpartum hemorrhage are none, right? So if you can't get consent, I say that this is a life-threatening emergency. We actually go ahead and do it in that way. But I want to caution that this is something that requires some expertise, and only folks that have some expertise in doing procedures in medium and small size vessels should really tackle this. So every now and then I hear some OB that says, oh, can you teach me? I don't know where this interventionalist is in my small town community to do this, but these complications are real, and there actually don't seem to be that much in our hands when you're a trained interventionalist, but they can actually be real. So complications of inadvertent embolization, ischemia is not a thing that we see a lot of, but non-target embolization can occur. And if you use smaller embolic particles, then you can end up with some gluteal ischemia. Let's look at this other case real quickly. It's a 32-year-old, again, presented to L&D 41 weeks and 1 day, prolonged delivery, ended up with an emergency section. And again, when they're doing everything else that they can do and they can't stop the bleeding, then they will do tamponade, uterine tamponade effect with this Bacter balloon. So after the patient had lost quite a bit of blood, 11 units transfused, then we were called to look at this case. And I always start off with an aortogram, and not everyone has to do this. I'm just showing you my own technique, and that you need to wait a little bit for the delayed filming, because sometimes these patients are quite hypotensive, so that you can see, this delayed blush, and looking for frank extravasation is not needed for treatment to happen. So remember that we're first doctors, and yes, we're doing embolization, but these patients are quite unstable. And so the benefit of interventional radiology is not just that we can do that, but we can help to stabilize the patient. We can place lines for access. We also know how to resuscitate the patients. Do not forget your regular, instead of ABCs, I believe it's CABs nowadays, right? So we placed lines, resuscitated the patient, and absolutely we were able to to find the bleeding source and stop the bleeding here. So here you can see once we were able to get into the uterine artery, frank extravasation that was treated with gel foam, and the patient continued to deteriorate. It's very hard to see here, but we finally had to place a coil right at the end here. And the satisfaction is, do not stop there. You must look at the other side, the ipsilateral side, because you can actually, just like if you're doing fibroid embolization, get collateral flow across the uterus and also continue with the bleeding. So this patient did well and went home. Unfortunately developed a few AKI, and again I put this in here just to remind you to be conscious a little bit of your contrast dose. I know that we're saving someone's life and no one wants to be thinking about how much contrast that you're needed, but to mom it can be quite devastated if you're putting someone on dialysis even temporarily. So I want to switch a little bit and talk for like 2 more minutes about abnormal placentation. So abnormal adherence to the placenta into the myometrium is a serious and life-threatening problem and a very rare contributor to postpartum hemorrhage, but definitely can happen. I won't go through all of this, just know that there are 3 types, that the incidence is increasing in the United States, and that this gives us an opportunity to actually proactively do something about hemorrhaging instead of reactively doing it when they're calling us. So a multidisciplinary consultation with your OB colleagues is critical when we're dealing with these patients. So these patients typically have imaging ahead of time. This is an MRI that shows the placenta percreta. And sometimes you can have ultrasound. This is one of our patients, 35-year-old, that had 2 previous pregnancy, had that MRI that was seen in an ultrasound showing a full percreta. So in this patient, they decided they wanted to have balloons up. The patient was at term, and you can see that a C-section still had to be done, lots and lots of packing as they were trying to move things around. Only one of the balloons ended up being able to be there. And I don't want to get into the pros and cons for balloon versus coils versus gel foam, but if you're studying for the board's exam, you should say thick slurry gel foam when you're asked about this. So this is another patient, and I wanted to bring this in because a part of what we're doing here in this women's seminar is that we're all about saving lives. All right, we're saving the life of the mother, we're saving the life of a child. And sometimes we are only able to choose one. And this is a 30-year-old with placental abnormality, vaginal bleeding, had been bleeding and getting transfused for days. So the patient came from out of state and had this MRI at Emory showing a full percreta with invasion of the bladder and the rectum. We ended up having to do an embolization ahead of time to save the life of the mother, and the patient went subsequently to the OR to have an in situ hysterectomy. And you can see how these abnormal placentation that grows all the way full thickness through the uterine wall. There is only thing that we could do here is to save a life of a child. And I'm going to stop in a second. And I want to say that, whatever you can do meticulously with your techniques, paying attention to where your catheter tip is, that is what we need to get done. I am not so dogmatic about whether or not we're using, for your boards, you'll say gel foam. I know that there have been articles that have described glue being used in patients with DIC with good success. I'm not here to knock that out, and even coils, right? Especially if there's a pseudoaneurysm or laceration and you can't get beyond where you need to go, please do whatever you can to stop the bleeding at the time safely. So always when we talk about women, it's always, what about pregnancy, right? And so I say that we know that there is no evidence at all implicating pelvic embolization as causing infertility in this group. And there have been, in fact, numerous successful pregnancies that have been reported in women that have undergone previous bilateral hypogastric artery ligation. And definitely pregnancies that I know I've seen for my patients that have had embolization for postpartum hemorrhage. At this time, there are no reports of infertility or fetal intrauterine growth restriction in patients with post-embolization syndromes that have emerged. So I've kind of given you some of what has happened, and we're going to be talking a little bit with Dr. Gachoya about what our data is telling us about the future. So I'm going to move over.
Hello, everyone. My name is Judy. I work at Emory University, and I just want to explain to you some of the things that we're starting to think about. So instead of thinking of maternal mortality, the new sort of incentives are around severe maternal morbidity, and those are just thought of as the near misses because those provide such a big opportunity to improve. And so we've had state level guidelines, change in policy, including obstetric bundles and hemorrhage bundles to sort of encourage at the state level and the facility level to review maternal morbidity. And so we know that severe maternal morbidity also disproportionately affects racial and ethnic minorities. It's preventable, and some of the early studies, especially from Australia, have showed that this is very provider dependent. And so given the fact that we know most of our times that IR is called late, and usually it's because there's nothing else to do, you're not involved early. So we envision that this new framework of thinking about severe maternal morbidity is important and provides an opportunity for IR. And so at the moment, we don't have any clear guidelines for endovascular therapies for severe maternal morbidity, and there's no common lexicon. And in Atlanta here, we have one of the largest trauma centers, but every time you say, level 1 trauma, when you tell the patient transport, the nurses, the CT tech, everyone understands what that means and the seriousness of that, and even anesthesia, but we don't have something similar in terms of a lexicon for severe maternal morbidity. And obviously we have no consensus guidelines, and IR is truly not at the table for SMM. And so we are trying to approach this with a data-driven approach, first by aggregating data. We are lucky here in Atlanta, we have some actually, Emory is one of the largest centers that has deployed a sepsis algorithm in practice, which was super helpful in the COVID care. And we're starting to leverage availability of that infrastructure to be able to at least get data like how much, how many women are getting massive transfusion, how many people are, what's the estimated blood volume, so that we are not always surprised, but we can also have an opportunity for early intervention. We envision that we can use some of this data to develop a bleeding risk index, and maybe hopefully one day move to a lexicon. Obviously, this is going to require the support of everyone. And so if this is of interest, you can reach out to us, and where we can say that there is this, level 1 trauma for equivalent for severe maternal morbidity, and everyone will come to the table with an appropriate response. And so in conclusion, 90% of maternal mortality or morbidity are preventable. Embolization remains effective, uterine sparing, and prevents a safe modality, but more is needed. Protocols should include IR, and preferably early in the process, and alongside the surgical interventions, which have a clearly established algorithm in OB. And so obviously we need physician and patient education, and specifically to be able to get to achieve best results and save mothers. And so we have to realize that every team member has a vital role, and we have to recognize all those members who guide the patients through their birth experience. We know that this is a process that starts 9 months before we actually end up being involved. And so working as a team, I think we can all end up having a win-win for mothers and parents. And so we imagine a world where no mother needlessly dies or is injured giving birth. And thank you. And these are some of our references that you can go through for this presentation.
Thank you so much. It would be nice to live in that world. I'm a fan. So at this point, I would like to introduce a woman who teaches me every time she speaks, Dr. Gloria Salazar, who's from MGH, who's going to talk about an entity that I still refer to as pelvic congestion syndrome. So hopefully Gloria can set us all right if that's what we say or not.
Okay, thank you so much. I want to say this lecture of postpartum bleed was one of the most important that I've ever heard. Congratulations. I was going to start differently, but now I have to say this. Dr. Newsom, very inspiring. And I would say that, you know, I actually entered medicine because I wanted to become Doctors Without Borders. And then in Brazil, my mom said to me, forget about it. Brazil needs help from you right here. And unfortunately, I'm seeing the same things happening in the US. And so we need to do it. And yes, we always talk about collaboration, but it's on us interventional radiologists to actually move that agenda forward. You can't be sitting in your clinic and not talking to other people. So hopefully we can actually do that and do more and more. And so, and this session could very well be called like saving the uterus, because this is what we're doing. And another way of saving the uterus is not having those pelvic congestion patients getting hysterectomy, even though the insurance don't cover. And these are my disclosures that are not relevant to this talk. And I'm gonna just really break down this lecture in 3 different things. The first thing is why is that pelvic venous disease is important, pelvic congestion syndrome, who should have treatment, and how treatment is done. And I'm gonna focus on 3 different types of things. The 5 reasons why are very well sort of laid out here for you, whether you see women in practice because you do have a great relationship with a gynecologist, or whether you are in a venous center, you're gonna see patients both ways. So first of all, this was already said, chronic pelvic pain is very common. Out of 10 to 40% of outpatient gynecological appointments, of those, 30% of patients can have pelvic venous disorders. And an additional 15% have combined disease. So you can have fibroids and pelvic congestion syndrome or endometriosis, et cetera. 1/3 of cases of chronic pelvic pain are due to pelvic venous disorders. And again, you know, we do not know the true incidence of this condition, but this is just a little bit of data for you to guide your practice. Now, if you do have patients that have non-saphenous veins, varicose veins in the legs, you can have pelvic venous reflux present in at least 17% of patients with recurrent vein after surgery, recurrent venous disease. And 10% of patients with lower extremity reflux can arise from pelvic pain. So whatever way you look at, you can actually see those patients. So the question then becomes, okay, so I'm treating pelvic congestion. It's an important topic, but where do I look? And really you have to look in 3 different territories, the internal iliac veins, ovarian veins, and left renal vein. And I'm gonna talk only today for the purpose of this talk about the reflux portion of it. So I'm gonna talk about internal iliac vein reflux treatment and gonadal vein reflux treatment, and also touch on the escape points, because these are really topics that are important for you to have successful outcomes. So let's start about talking a little bit about our venous anatomy issues. Usually is often the reason that women develop pelvic varices is multifactorial. There is a component of dilatation of the vein. However, even for the size of the ovarian vein, 10% of women may have dilated ovarian vein, but only 60% will develop pelvic venous disorders. So that is important for you to put into context the clinical symptoms of the patients, because you can have dilatation of gonadal veins without any symptoms. So we do know also that ovarian vein diameter does not correlate very well with the vein insufficiency. And so that paired with the fact that in terms of venous valves disease, venous valves in cadaveric studies are found to be only present in 10% of internal iliac veins and tributaries. So this may contribute to further to the issue. The lack of valves in those anatomic territories can also be a factor, as well as you don't see venous valves in the ovarian vein, in the left ovarian vein in 50% of patients and 6% of patients in the right ovarian vein. Now, this is all great and good, but if 90% of women don't have valves in the pelvis, in the venous anatomy pelvic, why is that we don't see more pelvic venous disorders? Well, the answer is you have to correlate with clinic. So this is the checklist that I utilize, and we know that pelvic pain due to pelvic congestion syndrome is usually defined as 6 months of chronic pelvic pain. And for me, the most important part of the clinical history is the 3 Ps, as I call it, the pain that is postural, that is postcoital, and chronic pelvic pain. So the 3 Ps are very important. It's also important to rule out obstruction in those patients, depending on the age group, and associated conditions such as hematuria that can point out more to a nutcracker syndrome. Again, I already mentioned this. Most of my patients that I see are both from varicose veins clinic, but also from a gynecological clinic. And usually those patients are already on trial of ovarian suppression. I always rule out all the other things that could cause chronic pelvic pain, which we already discussed extensively in this panel. Now, moving on to treatment, there's a bunch of things, including hysterectomy. Medical treatment probably is the most commonly done. Ovarian vein ligation can be done open or laparoscopic. Data is not really great. And hysterectomy, unfortunately, is still the main the main player, the main type of procedure that is performed for those conditions, partly due because of the lack of data, the high quality data that if we compare to UFE was extensively studied in randomized trial and level A data, but pelvic congestion syndrome, unfortunately, there's a lot of data all over the place. Now, hysterectomy is also not all that good. We know that 30% of patients can still have chronic pelvic pain from residual pain. And not only that, there is a recent paper showing that women who undergo hysterectomy for benign conditions, not cancer, they are at higher risk for mental health issues. And that is something that we need to tell our patients as well. I don't want to have depression and take my uterus out. So these are things that you need to consider when you're talking to the patient. So interventional procedures, I already mentioned the data is not all that great, partly because I think there's different anatomical sort of territories that are affected. There's also all sorts of combinations of procedures, ovarian vein embol, sclerotherapy for pelvic tributaries, and internal iliac stenting, which we're not gonna talk in this talk, but that's also a component that is important to be mentioned. So I am going to summarize really 20 years of data. We started in 2003 performing those procedures with coil embolization of the ovarian, left ovarian vein. This was the only randomized trial that was done, and there were some flaws in the design of the study. This was gonadal vein embolization compared with hysterectomy and with good results. And then we moved forward to learn more about our procedures and started doing bilateral gonadal vein embolization, and then more recently doing a combination of gonadal veins with the pelvic veins as well. Now, the meta-analysis that I'm mentioning is the results of 20 plus studies, including the randomized trial from 2003. The conclusions are that there's no high quality data for pelvic venous disorders. However, the effectiveness is thought to be 75% of substantial pain relief for women. And I'll take that over having my uterus removed any given day. So this is what you need to tell your patients. Yes, the data is not great. 75% may be good enough, all right? So in this meta-analysis as well, what the authors highlighted is most of the cases were done with coil embolization alone. Again, a lot of debate whether coil, whether foam, whether both, and that most of the patients were reproductive age. So this is also important because we're seeing more patients now, at least in my practice, with compression of the veins in the left iliac vein. When we talk about reflux, I'm gonna go back to 2009, and it's important for you to know reflux is not only the ovarian vein, it's also the internal iliac veins. I already talked about the lack of valves in this anatomic region, and here's a study from 2009 showing the different distribution of reflux in pelvic congestion syndrome. And that's just to show you that you need to evaluate everything. So moving on now for the procedure, I actually look at everything, and it obviously depends on how much studies, how many MRIs were done before my procedure. I usually only require an ultrasound showing me the cross-pelvic collateral in the grayscale and the dilatation of the veins. But sometimes I do also have cross-sectional imaging. But during my venography, I evaluate the IVC, the ovarians, the renal, and the internal iliac veins. And then I move on to proceed to ovarian vein or with or without internal iliac vein embolization. And there's many different techniques that we can describe. Now, it's worth noting that Society of Vascular Surgery guidelines recommend coil embolization plus sclerotherapy as standard treatments with a 2B level of evidence for pelvic venous disorders. And that's also to show why the data is so heterogeneous in the literature, because you can do just about anything. In terms of the access, I started doing this from a femoral approach, and I moved towards a jugular approach, which I think is more straightforward for me personally. And then you can do also breakout approach or veins in the arm. And a lot of people do that, particularly in Latin America. And you can do everything from one puncture if you need to, the evaluation of the patient. So here are two different procedures, 3 different patients from using femoral and transjugular approach. And then when I start with my venography, it's extremely important to prepare the patient and the breathing and the Valsalva, because that's when you get the diagnosis done. In still venography is the gold standard for the diagnosis. So this is a patient whom I did the venography, there was no reflux. The second one, absence of reflux. Again, you're not demonstrating the gonadal vein may or not be dilated. Again, we don't have the correlation, and this is a true positive, where you can see the reflux and the cross-pelvic collateral veins and some of the drainage into the internal iliacs. I also look for the internal iliac insufficiency. So I do venographies and take a look at whether there's reflux in the pelvis or not. And then finally, once I determine those and rule out compression, I go ahead and embolize and catheterize both ovarian veins, right and left, and then go distally. And that's usually when we start variating or deviating or changing the approach depending on what's your preference. So what do we do now? We have the catheter all the way in the pelvic frame. You see all those collaterals. So what to do? So a lot of people do different things. Some people inject sclerosants alone. Some people do a combination of coils and sclerosant and coils alone. So just about anything. In terms of the sclerosant agent, I think the most commonly used is sodium mauryate in the literature and in Sotradecol. But you can also have reports of glue and onyx. I've seen a couple of cases. And then coil embolization, and you usually size it with oversizing of about 20 to 30%. This is a patient of mine who had chronic pelvic pain. She was offered hysterectomy. She's like, I'm not gonna have it, so I'm gonna go and look online for other options. And she found me. And so we ended up doing, there was just one gonadal vein that was refluxing. There was no pelvic insufficiency. And I ended up doing just coils, like a very heavily packed coils alone. And this is before and after MRI. You can appreciate the pelvic varices are no longer there after treatment. And she did very fine, very well with the procedure. Now, I have changed my technique over the years. It depends on the patient, really, the anatomy. If I do have a single vein, then I just coil embolize, but mostly I'm doing sandwich technique and also embolizing the internal iliac vein, depending on the findings. The embolization of the internal iliac veins is sometimes needed to actually improve the efficacy of this procedure. And there's a lot of debate whether you should use sclerosants or coils. In terms of the technique, the way that I do this procedure is using balloon occlusion catheters. Once I identify the reflux and the pelvic varices, I place the balloons and I inflate them and then determine the amount of contrast needed to fill the varices. And then I go ahead and treat with the Sotradecol, with my foam sclerotherapy, and keep the balloons inflated for a couple of minutes and then deflate. That's the technique. This is a patient of mine who only had reflux in the internal iliacs, did not have ovarian vein reflux, and we did embolize with just with sclerosant, balloon occlusion sclerosant. She did fantastic. She loves me now. She has 5 children, and she can actually have a better quality of life. Moving on now from the pelvis, you really have to pay attention to the escape points, as we call it, the connections with the distal tributary veins and also the veins with the leg. And usually we look for the obturator, pudendal, and gluteal escape points. And how do you look at that? This is a nice paper showing the anatomical sort of connections with the internal iliac branches and also the communications with the leg veins. For me, I think the most common in my practice is the inferior gluteal vein, but you can also have the obturator and causing, and the pudendal vein causing vulvar varices. How do we evaluate for escape points? It's extremely important that you can actually use a balloon because then you can see the connections. This is an inferior gluteal vein that you can see, or you can distally catheterize depending on if you already have cross-sectional imaging and you can see that. It's extremely important to look at those and treat them. And the treatment may vary. You may do a combination of coils and sclerosants or just coils alone. I'm just showing you here the data of the most sort of important articles showing the combination of sclerosant and coils. I think this is the most commonly used technique in the literature and probably outside of the literature in real practice. And just to show you the results, most of the outcomes that we measure is pain with the visual analog scale, which is not all that great, but that's all we have. And most patients decrease their pain after 12 months. And it's a relatively sustainable decrease in pain. This other paper from 2006 showing 80% significant improvement of pain. And here Leal Monedero paper showing about 50% in 6 months, but then, you know, after 6 months, you continue to have that effect depending on when you're looking at the data. And then also for patients with varicose veins as well, significant decrease in the pain and the VSS scores if you're combining those treatments with varicose veins. One word of caution, and this is my own case, you know, you need to be, usually I use detachable coils for this procedure. And here's the reason why, because if your catheter becomes unstable, you can always grab it or you can, you know, you have better control. The coil embolization, I think, is the worst outcome that you can have, and that's something that usually happens at the procedure. And it's usually when you're embolizing internal iliac veins as opposed to the ovarian veins, and these are the sort of different authors' incidence of coil embolization. Just need to be clear and good in technique and use coils that are safe. In terms of the meta-analysis reports for pelvic venous disorders, I know we do not have very great data, but in this study, the authors found no predictors for clinical improvement, but they found that best results are in multiparous women. Coils alone have about 89 to 100% clinical improvement versus the sclerosants, it's about 75. And short-term pain and fevers are more common with sclerosants, and I think it just only makes sense because of the fact that you're using more of inflammation in closing those veins. So I'm going to conclude my talk here in acknowledging the lack of proper or robust data, but the importance of us having proper diagnosis and patient selection is key, in particular because you want to avoid a hysterectomy. In ovarian vein, internal iliac vein embolization are actually low risk outpatient treatments that if you give me 75% improvement, I'll take that over having my uterus removed. And last but not the least, this is why we do it. This is a patient of mine who is very grateful for the validation of that she's not crazy, first of all, because she has chronic pain that never was diagnosed as pelvic venous disorder. And then she's also acknowledging the importance of spreading our expertise and knowledge in the community. And this is what we're doing. Thank you very much for inviting me for this. I'm very honored to be part of this panel. And this is really amazing that the SIR was able to put this together virtually. Thank you.
Thank you so much, Dr. Salazar. Thank you for all you've done for these patients. And thank you also for educating us on a topic that I think people have often a lot of lack of clarity on. So thank you so much. Our next speaker will be Dr. Gloria Huang from Stanford University, who will be speaking to us about the role of interventional oncology in breast cancer. Thanks for joining us, Dr. Huang.
Thank you so much, Vivian. Thank you, Maureen, also for inviting me to this talk. I have no financial disclosures. And so I'm going to be talking to you about the role of interventional oncology in breast cancer. Why is breast cancer an important topic for interventional radiologists to learn about? Well, let's see if I can arrow this forward. The unfortunate truth is that 1 in 8 women will be diagnosed with breast cancer in the United States. That comes out to 3.5 million women who have a history of breast cancer in the US, and that includes those who are currently being treated and those who have finished treatment. Over 276,000 women will have a new diagnosis of breast cancer in 2020. Aside from skin cancer, breast cancer is the most common cancer diagnosis in women, and it's the second most common cause of cancer death in women after lung cancer. Of relevance to IR, 20 to 30% of these women will develop metastatic disease, meaning that there are 155,000 women in the US living with metastatic breast cancer. 15% of those women will develop liver metastases, and unfortunately, the presence of liver metastases confers a poor prognosis for women with breast cancer. Since liver-directed therapy is our area of expertise, it's our job to figure out how we can participate in the care of these women. What's considered the current standard of care for these women with breast cancer? Depending on the molecular profile of their cancer, they may undergo endocrine treatments, CDK or K4, CDK6 inhibitors, targeters of HER2, and chemotherapy. Interestingly, last year, the NCCN guidelines suggested that after 3 lines of systemic chemotherapy, further chemotherapy treatment might not be helpful. They actually removed that language in this year's guidelines. There's also been a relative explosion of new biomarker-based therapies, which are now considered viable options for these patients, including checkpoint inhibitors. But what's glaringly absent from these guidelines for patients with metastatic disease is the mention of liver-directed therapies or even surgical resection for oligometastatic disease. The absence of minimally invasive therapies in breast cancer guidelines historically has limited us limited our role in caring for these patients, and also the timing of when we are called in. Here's a typical case of a referral for a breast cancer patient for liver-directed therapy. This young woman had cycled through numerous combinations of systemic chemotherapy, hormonal therapy, and systemic therapy for bone metastases, and at the end of it all, has liver progression. At that point, we're asked how we can help. This raises the question of which liver-directed therapy is best in a case like hers. The two treatments we currently have available for widespread liver metastases are radioembolization and chemoembolization. So let's start with the data on radioembolization. There have been a number of institutional studies looking at radioembolization using resin or glass microspheres for the treatment of breast cancer liver metastases. Both lobar and whole liver treatment have been performed, and the median survival has varied from 6 months to greater than 14 months. A structured review of the results of radioembolization demonstrated that radioembolization has a disease control rate of 70 to 96%, defined as stable disease to complete response. Of note, radiographic response does correlate strongly with survival. Patients who undergo radioembolization for breast cancer metastases experience the typical constellation of toxicities associated with this treatment. This begs the question of how to select for patients who will do well. A publication from the University of Bonn and a review out of Northwestern University touch on prognostic factors. Not surprisingly, lower disease burden, a healthier liver, and better ECOG status confer a better prognosis. While the data from Germany suggests that patients who have undergone fewer lines of chemo before radioembolization and undergo chemo after radioembolization have a better prognosis, it's possible that there is guarantee time bias that would explain those survival results. What about chemoembolization? Evaluating the efficacy of chemoembolization is pretty complicated given the heterogeneity of data with the wide variety of drugs used, as well as differences in selectivity of delivery and differences in the underlying patient populations studied. As a result, median survivals vary from as little as 6 months to as many as 47 months after treatment between the different studies. Two of the more recent studies using doxorubicin-eluting beads have shown median survivals of 16.7 and 47 months. Like with radioembolization, the disease control rate is variable, but lies somewhere between 40 and 100%. Like with radioembolization, those who demonstrate radiographic response show the longest survival. Data from Pittsburgh suggests that if a patient's going to respond, that should be apparent by the third chemoembolization. And that group also found that single agent doxorubicin was better than multiple agents or oxaliplatin alone. Another study looked at patients who received chemoembolization and systemic chemotherapy concurrently and found improved survival in patients who received concurrent TACE and chemotherapy when compared to chemotherapy alone. There are few studies that directly compare chemoembolization and radioembolization. One retrospective single-center study at Washington University showed possibly better tolerability of radioembolization in regards to adverse events and overall survival, but the study admittedly had a number of limitations, including possible selection bias between the two patient populations. Let's move on from transarterial therapy to percutaneous therapy. The next question is whether thermal ablation has a role in breast cancer metastases to the liver. Based on the few publications available, the median survival is quite favorable for patients undergoing thermal ablation to the liver. As you can see, the range here is from 26 to 60 months. Given the relative paucity of data on thermal ablation, it's worthwhile to also look at the literature on surgical resection of breast metastases to the liver. A systematic review of those studies showed that patients who were surgical candidates and who underwent surgery extended their median overall survival to 36 months. The survival statistics for surgery appear to be similar to those for percutaneous ablation. As with surgical resection, recurrence within or outside the liver will occur in the vast majority of patients who have undergone thermal ablation to the liver. Despite that, patients who are candidates for liver ablation can demonstrate prolonged survival, suggesting that, like with oligometastatic colorectal cancer, there may be utility in targeting the oligometastatic disease in the liver of breast cancer patients. Lastly, I want to touch on the controversial topic of percutaneous ablation for primary invasive breast cancer. Percutaneous ablation has been shown to be able to treat small benign masses in the breast, such as fibroadenomas, with superior cosmetic effect and easier recoveries than surgical resection. For invasive breast cancer, there have been a number of series in which ablation, either cryoablation or radiofrequency ablation, was performed, followed by surgical resection, to look at the efficacy of ablation. Those studies have shown good technical success for tumors less than or equal to 1.5 centimeters in diameter, but the long-term efficacy was unknown because those patients had also undergone surgical resection. There are now 2 ongoing clinical trials, the FROST and ICE3 trials, to assess the long-term outcomes of ablation of small primary tumors without surgery. It's important for us as a group to be aware of a study that has been published. It's a multi-center American College of Surgical Oncology group study, which included tumors less than or equal to 2 centimeters, which found that ablation was successful in only 76% of tumors treated, as determined by the pathology of surgically resected specimens after ablation. Why the disappointing results? Well, the most common reason for failure in this group was the presence of multifocal disease, including DCIS, that may not have been appreciated on pre-procedure imaging, even on MRI. This suggests that we may need better detection of multifocal disease to assist with patient selection should we decide to treat primary breast tumors. Other causes of failure included incomplete ablation at the periphery of the tumor in a small percentage of cases, or the mistargeting of the tumor itself. Percutaneous cryoablation of breast cancer would be highly desirable, as it potentially could be performed without anesthesia or even sedation and reduces disfigurement of the breast. But until we can find the data or technique to support more widespread adoption, in the short term, there still may be circumstances where it may be appropriate for cryoablation of the breast, such as local palliation in patients with metastatic disease to prevent ulceration and fungation through the skin. I hope you found this review I hope you found this to be a helpful overview of the different ways IR has played a small role in the care of breast cancer patients. As you can see, there remains a lot of work to be done to demonstrate our effectiveness in improving outcomes in this important patient population. I hope that you will join me in looking for ways that we can expand our role in these patients' care. Thank you.
Thank you, Dr. Huang. I just wanted to take a moment and just say that I've been listening to all these incredible women speak, and I'm just so inspired and in awe of every single one. So I'm going to present our last speaker today. So this is an incredible up-and-coming star of interventional radiology, Dr. Ava Starr, who's going to join us from Vascular Institute of Virginia and talk about gender differences in PAD.
I had to unmute myself. So I'm Ava Starr, and I'm honored to be a part of this panel, actually representing a diverse perspective. I actually practice in a strictly OBL setting in a multidisciplinary practice with interventional nephrologists, vascular surgeons, general surgeons, and IRs. Unlike the other ladies on this panel, my specialty is complex limb salvage, and my true love is gangrenous feet and saving legs from amputation. So with that, I've been asked to speak a little bit on the gender differences in PAD. So let me see if I can pull that up, and for what we should think about when we're treating women in the clinic or in our procedures. So this is actually a short talk, which I'm sure it will be a relief to everyone since we've gone a little bit over. But the other reason it's a short talk is because we just don't have that much information, unfortunately, about gender differences in peripheral arterial disease and CLI. But one reason it's important is that women outlive men. So the burden of PAD is going to be higher in an aging female population. Women also tend to present with PAD at an older age and with more advanced disease, including femoropopliteal and multi-level infrainguinal disease, as well as CLI. Female gender has also been shown to be an independent predictor for severe atherosclerotic disease. Women do also have higher rates, and this is important when you're seeing anyone in clinic and when you're evaluating a female patient, women do actually have higher rates of asymptomatic and atypical presentations of PAD, such as slower walking velocity, poorer standing balance. It may take them a lot longer to arise 5 times consecutively from a seated position, and they may be able to walk fewer blocks per week. So that's important to bear in mind when seeing these patients in clinic and evaluating them, and maybe having a shorter metric to get non-invasive imaging on these patients as compared to men. Women with CLI also have higher readmission rates compared with men, so that's something to bear in mind when treating women with CLI. And there's thought to be a protective effect of hormones before menopause that then subsequently produces a more rapid progression of CLI in the postmenopausal state. So in terms of conservative management in women with PAD, there is, the existing evidence basically suggests that there's no sex-based difference with regard to the benefit of conservative management with supervised exercise and medical therapy with cilostazol or Pletol when women are compared with men. So in terms of claudication and conservative management, the best thing to do for both women and men is to start with those two therapies for conservative management. In terms of open surgical management in women with CLI, there is some conflicting evidence. Generally, there are some studies that suggest that women have higher incidence of graft failure, wound infection, and bleeding complications, including limb loss and mortality compared with men. And there is also some evidence that suggests that acute graft failure with prosthetic conduit is higher for women than men. There was definitely a large trial that found that after open surgical revascularization, women had a significantly increased risk of 30-day mortality, amputation, early graft thrombosis, embolization, incision site complications, cardiac events, stroke, and pulmonary complications. However, long-term outcomes after surgical revascularization appear to be similar based on the existing evidence between women and men. Men, according to some studies, are more likely to undergo surgical rather than endovascular revascularization, and also have higher amputation and mortality rates post-intervention compared with women. In terms of endovascular management in women with CLI, technical success rates of the endovascular approach are higher, have been found to be higher in women, but women have higher rates of embolic events. So that's one thing to keep in mind when performing endovascular intervention for CLI on women, or even for claudication if it's lifestyle limiting and they've failed conservative management. Improved patency rates are found after endovascular intervention in women, according to the literature, though they also found that limb loss rates may be higher for women. In terms of 5-year clinical outcomes following endovascular revascularization, they're similar in men and women, and this large trial found no statistically significant difference in major adverse cardiac events or major adverse limb events at 5 years. So overall, the existing literature does suggest that endovascular revascularization outcomes are the same for women as men, though there's some evidence that the success rates and complication rates may also be higher for women. There are a few additional interesting differences suggested by the literature in women with CLI. At least one study suggests that amputation rates for diabetic foot ulcers do not differ between women and men. And regardless of whether an open or endovascular approach is utilized, women with lifestyle limiting claudication or CLI admitted post-intervention, whether it was open or endovascular, do have higher inpatient mortality rates than men. Wound healing rates of lower extremity arterial ulcers have not been found to be significantly related to gender. And most importantly, women are grossly underrepresented in PAD and CLI clinical trials. And so that's definitely, there's room for improvement there. And if we can do that, we'll know better if there are additional differences that we need to consider. So this is just a table basically summarizing these findings of in women versus men, again, based on very, very limited data currently. So asymptomatic PAD and atypical PAD presentation is more common in women. So that's something to bear in mind when you're seeing these patients in the clinic. Supervised exercise outcomes and cilostazol, same for women and men. Readmission rates and amputation-free survival are higher in women. So in terms of open surgical revascularization, there's no consensus whether women have more complications than men, but the outcomes appear to be the same. In terms of endovascular revascularization, both the success rate and the complication rate appears to be higher in women based on limited data, but the outcomes of the endovascular revascularization seem to be the same for men and women. And in terms of ulcers, whether they're arterial or diabetic foot ulcers, and wound healing and amputation rates, those appear to be the same for men and women. They seem to be based on other factors that are not gender specific. and inpatient mortality is higher in women when they're readmitted. And there's a whole bunch of references here, and that's basically the gist of my talk. So we need more women involved in these clinical trials. We need more, I think, investigators running the clinical trials in the CLI space, and more collaboration will help with that, multidisciplinary collaboration, and that'll give us more data on how to treat women with PAD and CLI in the future, because women are living longer.
Thank you so much, Dr. Starr. That was fantastic, and rounds out our topic of saving the uterus with realizing that women have other parts of their body to save also. So thank you for bringing it back to a more whole body approach. So we are over time, but we also have several questions. We've been trying to answer them in writing on a rolling basis, but we have some time for a few questions and discussion. Several of them, I think, are directed to Dr. Salazar, so maybe we'll let her answer some of these questions regarding her technique for ovarian vein and internal iliac vein embolization and sclero.
Right, so the two questions are kind of related. When you do have nutcracker symptoms, like hematuria, back pain, plus the pelvic congestion symptoms, what do you do? So, I mean, you are not gonna treat the nutcracker by just embolizing the gonadal vein, so you're gonna have to consider placing a stent. The problem is that the stent literature is not all that great, and we do not have dedicated stents for that location, and we've seen some stent migrations with the stenting of a renal vein. I think the most important thing you should do, and I'm very lucky myself that I work in a multidisciplinary setting with the vascular surgeons, so sometimes I do refer for vascular bypass, because sometimes you may need to do a gonadal, depending on the technique, they can use the gonadal vein for bypass as well. But I would say that I would only embolize the gonadal vein in the setting of nutcracker if the patient is having symptoms of pelvic venous disorder without renal symptoms, which means no hematuria and no back pain. And I've done it with good results. I think that was one of the questions. So regarding the pelvic venous disorder non-responders and without evidence for other cause of pelvic pain, has there been an investigation association between psychological latent pelvic trauma and rape? Yeah, that's a psychologically latent pelvic trauma in rape, sexual abuse, and pelvic pain. So that's a good study to be done, because there's, it's not uncommon. I had patients in my practice that disclosed that they've been sexually abused in the evaluation and the workup of pelvic venous disorder. So this is an interesting question. Thank you for bringing it up. It's a real thing. If the patient connects with you, they're gonna open up about this and about other things. And whenever I have a case like this, I'm not a psychiatrist, I'm no psychologist, but I always refer to a psychologist. And no, there's no study that shows, what we know is that the patient's characteristics for pelvic venous disorder is that they are in chronic pelvic pain, they have some symptoms of depression, they have some other issues, but whether the symptoms of depression came first or not, or if it's just an association, we do not know that. That would be an interesting thing to look forward. Am I missing any other? How do you deal with escape points? Embolize them, find them and embolize them. I don't coil, I don't like coiling in the pelvis. I don't know, my colleagues, I don't know if you do that. Unfortunately, I've seen disasters because of the coil embolization. Somehow the pelvis is this reservoir that changes, and I don't know, it's just very uncomfortable. So just sclerose, and unless you do have a way of anchoring the coil, like putting the coil in a side vein so that you know it's not gonna move, and you size it very well. Let's see. What's the algorithm approach to venous congestion? How do we best exclude other organs? So usually for me, the patients already come with extensive workup, which also includes musculoskeletal issues, etc. And so I don't have a problem. But if I have a patient that has never been evaluated, I would do an MRI. That's the only issue with the MRI is that if you order it to rule out other causes, then you have different sequences. So usually I do the MRV, But if you're looking for fibroids and other things, you also have to work with a gynecological sort of workup at the same time. So that's the issue of referral. So if you get a patient referred from a primary care physician, make sure you have a gynecologist that you can partner with, so you are covered, so you are not missing anything.
Okay, thank you. There's one other question about UAE, which I'm just going to pose to the panel. Would you UAE a patient? Would UAE still be used for uterine inversion? I can't see why not. Maybe no. Yes, Janice. I see some head shaking. I guess it depends, not to fix uterine inversion, right? I've read that as if you had fibroids and uterine anatomical changes. So I guess that one baffled us all. But I just wanted to thank everybody. Does anybody from the panel have anything they'd like to talk about or discuss?
Yeah, I just want to say thanks to everyone. This has been a fantastic, fantastic session. And I do have to run away now. But it was just so wonderful to see all of you there and all of the participants. So many names that we recognize. So thanks to SIR, congratulations on another successful year. Although virtual, we can feel it in the heart.
Thank you. I just wanted to add to that I think it's important, the first talk by Divya about COVID and how does that impact women. I think it's just a suggestion, open suggestion. We should definitely talk about this because we already have a disparity in women going into IR. And I think now people who are leaders in IR are under extreme stress, not only leaders, but women in general. So I think we need to have a way for supporting each other, and hopefully as a suggestion for the next topic for SIR, maybe we should talk about this, like leadership, COVID, burnout after treating those patients, all those things that are gonna come up one way or another.
Maybe even as a suggestion, I think talking about the new pandemic, racism and hatred as it relates to our trainees as well as our patients and all of us.
Yes, absolutely, 100% agree.
So till then, bye-bye.
Bye, thank you to everyone.
Bye.
Thank you.
Thanks, everyone.